We're going to discuss some birth injuries now. Most birth injuries are related to large babies or some difficult presentations. Very important one for the exam is caput succedaneum and cephalhematoma, two kinds of scalp swelling. The caput succedaneum is basically just swelling of the scalp from the baby being stuck in the birth canal. For every contraction that the mom feels, the baby is also on the receiving end, and when the baby is born, you will notice some swelling of the scalp. We sometimes call them the conehead babies. These babies otherwise are fine. The scalp swelling resolves over the next few days. It can be a source of jaundice because there's blood collection there. The cephalhematoma is a little bit different. It actually gets worse over the first few days. It is a subperiosteal bleed. Since it is underneath the bone, it is limited to bone and subsequently will not cross the suture line. That's the most important thing you can remember for the exam, is that it does not cross the suture lines. Sometimes you can have a baby that presents with bilateral cephalhematomas, and at that case you will actually feel almost a groove between the two cephalhematomas because of where they end at the suture lines. These take a little bit longer to go away. You can sometimes feel what's known as a volcano or crater rim. Part of your differential diagnosis in this case with cephalhematomas is the depressed skull fracture, although the depressed skull fracture is more easily palpated and is not so much swelling as an actual depression. Here you see some scalp swelling. This is a caput succedaneum on the left. On the right is a cephalhematoma, which doesn't show as well as this one, where you can actually see where the bleed stops and the suture line is. Cephalhematomas will resolve sometimes over weeks or sometimes a month or so. You got to know the difference between the two of them. This is subcutaneous fat necrosis, all these little lumps that you see on the baby on his back. It is associated with difficult labor or delivery, also with perinatal asphyxia. That can be reflected in low APGAR scores. Also associated with prolonged hypothermia. These are firm, rubbery nodules. They really don't hurt much, but the moms see them and they report them to you. They tend to go away with time. The nodules occur anywhere, but very commonly will be on the cheeks and also in the buttocks. Look for forceps delivery. These sometimes will calcify, and so months down the road, the patient can have some hypocalcemia. This is what's known as Erb Duchenne palsy. Erb Duchenne is one of the brachial plexus injuries. There's two that you need to know, Erb Duchenne's and Klumpke's. Erb Duchenne is C3 and C4. Sometimes C5 is affected. In that case, you will have an ipsilateral hemidiaphragmatic paralysis, which may cause some respiratory distress in the baby. The next test to do for this child would be to get a chest x-ray, and you would see an elevated hemidiaphragm. You could also do an ultrasound and actually see the dynamics. As the baby is breathing, the diaphragm on that side does not move. This baby has the characteristic waiter's tip of the hand. This is the way that they arrange their hands because of the paralysis, and it's now the waiter accepting the tip. These injuries tend to go away with time if it's a mild injury. Sometimes they need physical therapy. The other brachial plexus injury that you need to know is what's known as Klumpke's paralysis. That is more C8 and T1 further down. Since T1 is involved, that involves the thoracic sympathetic ganglion, and you may have an associated Horner syndrome. The way to remember Horner syndrome is Horner's a guy whose forehead is dry, who has a small eye and can't see the sky. And that is the anhidrosis. That is the meiosis and the ptosis. Horner's can occur in girls, but it wouldn't rhyme, and the mnemonic doesn't work as well. The other thing that you see with Klumpke's is what's described as the claw hand deformity, and they hold their hand a little bit differently than these Erb Duchenne's do. Again, these may resolve with time if they're just mild, may need some physical therapy. This is a facial palsy affecting the facial nerve. If you remember from your step 1 studies, you need to distinguish whether it's a central or a peripheral palsy. The affected side is actually this side over here. The baby cries and the mouth doesn't draw down. The baby cries and the eye doesn't close. So this is a peripheral palsy because the fibers have already crossed, and so it's a peripheral palsy since the whole face is affected. The lower part of the face being affected indicates just a central palsy. Again, many times they'll get better on their own. This is a clavicular fracture. The clavicle is the most commonly fractured bone during delivery. When you're reading the stem of the question, look for a large baby, 8.5, 9, 9.5, 10-pounder. This is what you'll see. Many times the baby is asymptomatic, and the mom might bring the baby in at 1 week of age and describe a lump in that area. That lump is actually callus formation already. The baby's not been abused, the baby just had a fracture. You may read in the question, or they may describe an asymmetric Moro response, and that means that's also suggestive of a fracture. On physical exam, they will describe crepitus over that area. And crepitus is kind of like when everybody squishes that bubble wrap. That's what crepitus feels like, and that's very consistent with a fracture over that area in the clavicle. These generally don't require much therapy, and not many people use the figure of 8 on these little babies. They pretty much limit themselves in their motions. So look for a big baby and a lump in that area, crepitus. Subconjunctival hemorrhages can occur just because of delivery through the vaginal canal, and so they are feeling that force and that pressure, and it can have subconjunctival hemorrhages, which will go away with time. In older children, you can see that with persistent vomiting or coughing.